Okay. Welcome everyone to our December signature series. So glad that you're here and hopefully you're making your way through the end of your semesters and finals. I know it's a busy time of year for everybody, so I appreciate you guys all hopping on with us. I'm really excited to introduce Dr. Nick Christian, who's our signature series presenter today. He's actually a colleague of mine, and he is a addiction medicine doctor, and he'll tell you a little bit more about what it is that he does when he shares his presentation. But we're super excited to have him here to talk to us about substance use and addiction. And as always, feel free to throw things in the chat as they come up. And if you have questions that you'd prefer be asked anonymously, feel free to privately send them to me and I can make sure that they get answered when we get to Q&A at the end. So, Nick, thank you. I'll throw it over to you.
Awesome. Thanks, Kelsey. Thanks for the invitation. And this is so cool. Over 120 folks here. Um, as Kelsey said, you guys are welcome to just call me Nick. Uh, I will answer to Dr. Christian. Actually, I won't answer to Dr. Christian in this call. I'll only answer to Nick. Uh, I am in Baltimore, as Kelsey said, and I am what I call an addiction doctor. And so I did my training in internal medicine, and I did an extra year of a fellowship after my general medical training in addiction. And through that experience, I have become very, very comfortable with how to help folks with either alcohol, opioid use, stimulants like cocaine or methamphetamine, or even psychedelic drugs. Really, my experience in this field started even before my education. Um, I am from a small town in Ohio. And because I know that all of y'all are athletes, I was a three-sport athlete myself in high school, from a small town just north of Dayton, Ohio. I did football, basketball, and track, but I got tired of basketball, so I ended up wrestling for 1 year. I don't know if there are any wrestlers on this call, but I got my butt kicked because I just knew nothing about wrestling. But it was a lot of fun, and I got in really good shape. And so after high school, right around that time, or where I'm from, just alcohol is ubiquitous at a very young age. There's not much to do. And so I think that that kind of planted the seeds actually for the opioid crisis to hit my hometown really hard. And it wasn't until I was in med school where actually some of my friends unfortunately overdosed on opioids. And I knew these people. Like they were my friends, they were family, uh, they were great friends and great musicians. I play music myself, and so I collaborated musically with a lot of these people. And so I just knew them as just good humans before knowing that they were addicts or knowing that uh, they were these horrendous in this horrendous state that you often see in television or in the news. And because of that, I got exposed to the fact that a lot of these folks get don't get the treatment that they need and deserve, primarily because of the stigma around addiction, and because we often don't think of it as something that folks can get better from. And so that has inspired me, and still is my source of inspiration with folks that I treat here in Baltimore. I was formerly at the National Institute on Drug Abuse, and I was doing some research there. I've since transitioned into a more clinical role at the University of Maryland, where I see folks who are admitted to the hospital, who might have broke their arm or have consequences from their drug use. And their primary team is like, hey, would you be interested in seeing a doctor who specializes in addiction? I'll go see them and get them connected to the care that they need, not just while they're in the hospital, but also try to connect them to care when they leave the hospital. Um, I'm going to share my slides now. If anyone has questions or is curious about a career in medicine or a career in addiction medicine, please feel free to reach out to myself or Kelsey. I'm happy to connect anytime after this call. And as she mentioned, feel free to place questions in the chat box. And I'm hoping that today can be pretty interactive. I'm going to try to keep the slides to a minimum. But so please feel free to interrupt if this isn't content that you guys think is helpful, we can totally pivot. But I called this talk Addiction 101, and it's the basics. So, what is addiction? How can we stay safe ourselves? And how can we help others stay safe and get the care that they need? Y'all are ambassadors at your programs, and I think that the organization that you're a part of, the Hidden Opponent, is an amazing resource. And the fact that y'all are here shows that you're leaders in on your teams and in your communities. So I hope that this information can y'all can be disseminators of this and advocates for other folks who might need connected to this sort of care. So, to get started, to get to know where y'all are coming from, I'm curious, where are you located? Are there any other Buckeyes in the house? We're beat up today. I did my undergrad at the Ohio State University. We do have a Columbus, Ohio. All right. Connecticut. I'll go blue. Boo. Looks like lots of New England, St. Louis, a Clevelander here. All right. LA. Awesome. We span the whole US, it appears. And in West Virginia, I'll give you a shout out later, Allie. Uh, what's one way that you'd like to make a difference in the world? Awesome. We have a future counselor here. I love it. Make others feel seen, social worker. Some physicians here. Help people know they're not alone. Future nurse. Awesome. Supporting athletes. I'm sure that's a little bit of everyone here. Be kind to everyone. I often view that as if you can cover that, being kind, you're going to do great in whatever job you're in. As a matter of fact, a friend of mine who unfortunately has since passed, but he bestowed some wisdom on me. He was in med school with me, and he said, there are three things, and you only need two of the three to be good at whatever you're in. The first is just be kind, be nice. The first or the second is you just got to know a little bit about your field. So it's the content knowledge. Uh, and the third is if you work hard. So as long as you work hard and you're kind, you got two of the three, you're going to do great. If you're not kind, you can still be really smart, but and you might get a pass, but ideally you'd have all three. Support friends, support struggling communities. This is great. And then lastly, what do you hope to learn today? How to support athletes that might have addiction, what to do in tough situations. Yeah, okay, so warning signs. Great, we're covering that. Support without overstepping. Yeah, that's a big one. The hard conversations. I don't know if I'll make you an expert on having hard conversations, but hopefully today you'll have the basics for understanding what addiction is and how you can be that support for someone. Awesome. And I also should have mentioned that a lot of my experience as well came from during my residency training. I lived in a community that's housing folks who were once unhoused. And because of that, a lot of my neighbors had addictions, and I lived with them. I lived in that community for about 3 years. And so a lot of what I'm sharing with you is wisdom that has also come to me from countless other loving friends of mine that have had actual experience with this. So, all right, awesome. I think we'll be covering a lot of these things. So thank you for sharing. Um, and one last question before I launch into some content. What is addiction? What do y'all think? It seems like something that would be easy to define, something you can't seem to let go of. Yeah. I'm seeing a lot of uncontrollable. That's something I hear a lot of people say is it's expressed as this loss of control in one's life. Unhealthy dependence or reliance are a lot of common words I'm seeing here. Awesome. Well, for me in my field, there are a lot of ways to view addiction. Uh, some people say it's a battle, it's a spiritual battle between good and bad. There's this physiologic model. You can look at like what the drug is actually doing to the different parts of the body and why does that instill an addiction. You can view it as a disease, or you could view it in this bigger social scale of more like pandemics, like how why is it that fentanyl moved into the supply, and how is it that bigger systems play into accessibility to drugs or not? All of those things certainly contribute to what addiction is. I'm going to provide you with the very simplified definition that I use to talk to patients about, and then I'll explain kind of why I use that definition. And this is the definition used by the American Society of Addiction Medicine. We call addiction a chronic, treatable medical condition. Very simple, chronic, treatable medical condition. Now, why is it that we call it a chronic, treatable medical condition? Well, a lot of that is because we can see from a lot of imaging studies what is actually happening in people's brains during different phases of addiction. During the phase of the first phase of any addictive process is you have to be exposed to it. So we call that binge and intoxication. And anything in light blue here are the parts of the brain that light up when you use a substance. And you don't even have to use a substance. Actually, let's see in the chat box. Who knows what neurochemical gets increased during the binge and intoxication phase of addiction? Dopamine. Yeah, y'all were really quick on that one. So, and dopamine is that feel good sensation that we get. And it's a very normal, natural thing in our bodies. It's what allows us to do exceptional things like hard endurance training for our sports programs, or things that make us want to do a good job at work. Or when you get that like on Instagram and you look at it and that it feels good, like you get that hit of dopamine, and that affects a certain part of our brain called the ventral tegmental area, which is known as our reward center. So we can see that anything that we can ingest that we might consider a drug, and that's inclusive of alcohol, it all dopamine is implicated in this region for every single substance. After, for folks that repeat the binge and intoxication, often we fall into the second phase of addiction, which is called withdrawal and negative affect. So all of the red parts here are the parts of our brain that we see are hyperactive during the withdrawal state. The withdrawal state, we think, starts because when anyone uses a substance, we in our brains think that we're going to feel really, really good. But the reality is, when we use a substance, we never get to that point. And we can actually see that in studies of folks who use cocaine, that for someone living with addiction, if you just show them a cocaine pipe, for instance, if they were someone who had a cocaine use disorder, if you show a cocaine pipe, you see the blue region here light up really, really high. Whereas if that person actually uses cocaine, it doesn't light up quite as much. And so that suggests to us that the cues, we end up responding to these cues. And that difference between thinking you're going to feel this good and actually feeling this good is what drives folks into a withdrawal state. And it's that withdrawal state that activates what's called our sympathetic nervous system, which is our natural fight or flight response. We see increases in norepinephrine and in cortisol. And these are neurochemicals that make us feel stressed. It makes our body feel like we either need to run from something really bad or we need to try to fight it. And when that is hyperactivated, it then sends signals to the third part of our brain that's implicated in addiction, which is called our prefrontal cortex. And that third phase of addiction is what we call preoccupation and anticipation. And so become preoccupied with getting more of the substance so that we don't feel bad anymore. And the prefrontal cortex, or PFC for short, is a really important part of our brain in the addictive process. The prefrontal cortex allows us to make decisions for ourselves. And in most cases, we make healthy, good decisions for ourselves. But we can see that folks who have been sustained in the addictive process long enough that their prefrontal cortices actually atrophy or shrink a bit. And we can see on imaging studies that folks who have smaller prefrontal cortexes are actually more likely to return to using a substance. Uh, all this to say, the brain is highly malleable, and so you can exercise these parts of your brain. And so because the more that this process occurs, the more ingrained this neurocircuitry is in our brain. So the longer someone is using a substance in this manner and goes through all these phases, for some folks that have used for decades, like that neurocircuitry might be permanent for them. And that doesn't sound great, especially not to folks who are living in recovery. And that's because like just because this might be a permanent pathway doesn't mean someone's always going to be using drugs the rest of their life. We see so many people who live fruitful, happy lives despite having had an addiction at one point in their life. So that we know that this is exactly why we that neurocircuitry is permanent. That's why we call addiction a chronic disease. We also know it's treatable. And so that's why we call addiction a chronic treatable disease. And I hope to get to some of the treatments today. We won't have time to go through all of them. But that is, in essence, how I view addiction and how I talk to patients about it. That this neurocircuitry has happened in your brain and you have lost control over this neurocircuitry to some degree. But there are treatments that can help you regain some of that control. So, as I kind of alluded to, this diagram outlines like most of us in this call, I'd imagine, are in this normal state of being right now. We're not euphoric, we're not feeling bad, we're just in a normal state of being. We call that homeostasis also for those biology majors. That biology was my worst subject, by the way. I was the only class that I think I got a C in at some point. So, those of y'all who are thinking about going to medical school, you can certainly still get into med school even with a C here and there. So don't stress out too much about it. But when you are in the early phases of using a drug, let's say, for instance, I decide to use cocaine, or here, this is a good example that I'm sure a lot of y'all have faced. I decide to use my friend's Adderall. They have an extra pill of Adderall around. I use it the first time and I feel really good. If I try to do it again the next night, I'm probably not going to feel quite as good. And if I continue to use it repeatedly, I'm probably not going to feel as good every time that I use it. And we call that in the addiction field, a lot of y'all probably are aware of the term, we call that tolerance. Like our body naturally adjusts to try to allow us to live in a normal state. And ingesting a substance like Adderall which is an amphetamine, our body's going to try to downregulate those receptors so we don't get out of our natural homeostasis. Once we develop that tolerance and physical dependence, for some folks, when I don't have the Adderall, I'm going to feel bad at some point. And I'm no longer going to be using that substance to feel normal, or I'm no longer going to be using it to feel euphoric and feel good. I'm just going to try to use it to feel normal, um, which is totally appropriate for folks who have an attention deficit hyperactivity disorder or need this medicine to function in a normal state. But for someone, if I were to develop a loss of control with the use of this, I would be using it no longer, as I said, to feel good, but using it to not feel withdrawal or to not feel bad. And that's a pretty classic hallmark of addiction, is you're no longer using the substance to feel good. Like you have this switch to using because you don't want to feel bad anymore and you just want to live in this normal state. And this is especially true for folks who use opioids or fentanyl. And that is exactly the goal for treatment, especially for opioid use disorder, is to provide folks with a medication or with therapy or with whatever treatment's working for you. Provide that so that folks can stay in this normal state of being. And I just wanted to preface that, like, covering the brain model of addiction and calling addiction a chronic treatable medical condition, it kind of fails to capture the fact that addiction just sucks. Like it really, folks that experience addiction, they're not proud of what they've experienced or what they've had to do to sustain their new homeostasis. And because of those decisions that folks have had to do, it often affects the lives of the people around them. And so addiction is just one of those rare conditions that not only affects the individual, but it affects the people who love them as well. And it's heartbreaking to walk with folks through their addiction. Um, and I hope that if you get anything from this lecture, it's that there are treatments that can help folks, and continuing to love them is probably the best thing that you can do for them. That we often hear this term tough love, and some folks use that term tough love to help them to create barriers so that they aren't hurt as bad by the individuals experiencing addiction. I would argue that the term tough love probably isn't as accurate as just saying giving love to someone. And anything you can do to remind someone that you love them, despite, and you care for them, and you care for them, even in spite of what they might be going through in their life, will plant the seeds to help combat their addiction at some point. And I've even heard it said there's a gentleman by the name of Johann Hari who has written several books on addiction. And I'm blanking on the name of one to recommend. So if you're curious, I'm happy to put that in the chat later and look it up. But he says that the opposite of addiction isn't abstinence. Like the opposite of addiction is connection. And addiction is often a lack of connection to anything other than the substance. And so anything you can do to help folks feel connected will inevitably help them in their recovery process. And I see a question from Braylon. Why do people still do it and try it if they know what could happen? Well, I think the reality is not everyone knows what could happen. And I think that society has done a really bad job at educating on what addiction is. And furthermore, what do y'all think? Do you think that that the majority of folks who try a substance, do you think, or of folks that use substances, do you think the majority develop an addiction? Or do you think a small percentage of folks who try drugs develop an addiction? We can use cocaine, for instance. What do you think? Do you think the majority of folks who try cocaine actually develop an addiction to cocaine? Yeah, and how about like alcohol and even heroin? Um, all of and even cigarettes, like you name it, it is actually a small percentage of folks who try any of these drugs that I mentioned develop an addiction. We think that the rates for certain substances, like heroin and fentanyl, like might be a little bit higher, but it's still not the majority. It still less than 50% of anyone that has tried these drugs develop an addiction. And so I think we've done a bad job as a society educating folks because I think that a lot of people think, oh, I tried it. I don't have an addiction right now. So everything I've heard about drugs, the don't ever do drugs stance, is wrong, right? Because I didn't develop an addiction. But the reality is, like, not everyone's going to develop an addiction, and I think it's important that we remind each other that yeah, trying a drug might not cause an addiction, but it's the repetitive use, and it's also certain individuals are more likely to develop an addiction. And we know that greater than 50%, upwards of 70% of what causes addiction are actually in our genetics, things that we can't even change. And they've even done twin studies of looking at like, is it nature or is it nurture? Like, is it that it's the genetics you're inheriting, or is it that there was alcohol in your home growing up? And we can tell that, like, yeah, the nurture is important, that if there's alcohol in your home, it does play a role. But actually, the genetics are way more predictive of if someone's going to develop an addiction or not. And we also know that folks that have had challenging upbringings, that have experienced what we call adverse childhood events, or ACEs, for those that might have read about this, are way more likely to develop an addiction later on in life. Folks who have experienced trauma. And a lot of this goes back to the brain model that I described, that anything that hyperactivates our fight or flight response, we know that that is a part of the addictive process. So we think that that's at play in what predisposes folks to potentially developing, predisposes some folks to developing an addiction. And I won't spend too much time on this, but because I already went on a long tangent about it. But there is an important difference between using a substance. Uh, Not everyone that uses a substance develops what we would call a substance use disorder. And then addiction is something even bigger, and is a little bit harder to define. As I said, the definition we use in my field is it's a chronic treatable medical condition. But let me show you some of what I'm talking about in terms of the spectrum of substance use, and then what we would consider in my field problematic substance use, or a substance use disorder, which is the diagnosis that I make as a doctor saying, hey, you meet the criteria for this diagnosis, and how can we get you treatment? So there's a huge spectrum of drug use. Some people don't use any drugs at all. Some people just use in experimental situations or use in social situations. Some folks use regularly. A lot of the folks that I see that are coming into my office are using more in this range of the using a substance habitually or daily or in a chaotic fashion. But this actually isn't it, the amount that you use actually is not what we use in my field to diagnose if you have a problem with drugs or alcohol. What we use in the field is what's called the DSM-5, and it's a manual that has all of the different criteria for diagnosing mental illnesses. In particular, or what we're talking about today, are substance use disorders. Or let's say, for instance, I'm someone who uses alcohol. If I meet these criteria, there are four criteria around impaired control, like using larger amounts over a longer period of time, trying to quit in the past but not being able to, having cravings, spending a lot of time using the drug. If I'm not fulfilling my roles, if I quit the sports team, and I used to really enjoy that, if I'm neglecting my role as a friend or as a parent, if I have interpersonal problems because of use, or I'm using the example with alcohol, if I'm getting behind the wheel of my vehicle after drinking, that would be considered hazardous or risky use. If I'm waking up with hangovers and I know it's impairing my performance in my job or in my sport, that means I would be using despite knowledge of physical or psychological problems. And then there's two pharmacologic criteria of if you experience withdrawal when you don't have the drug, or if you're having to use more of the drug to get the same effect over time, or tolerance, as I alluded to earlier. So if I'm someone who drinks alcohol in this way, and I meet 11 of the criteria, if you have six or more, you are diagnosed with what we would call a severe alcohol use disorder. If I only have four or five, I would have a moderate alcohol use disorder. And if I have two or three, I would have a mild alcohol use disorder. Now, why do we distinguish this? Well, in order to study something and to know what treatments work for folks, we need to have diagnoses so that we can diagnose people and then try treatments for them. We know that folks who diagnose for a severe use disorder, they always benefit from treatment. And that's what's studied in a lot of studies. But we also know that folks who have a mild use disorder, they also can benefit from certain treatments. And so that's why we use these diagnoses. And there are some people in my field who would say that an actual addiction isn't developed, or we would say someone has an addiction when they meet a severe use disorder. I think that making that distinction isn't all that important. So, because we also know that addictions can be things like I'm addicted to my phone, and that might not be causing social impairment or all of these things. And so, to me, I try to tell folks that addiction is kind of a tough thing to define. We use the term so much in society that it's kind of watered down and doesn't mean much. But to me, in my medical field, we use a use disorder, and that is what's more helpful in talking to patients and diagnosing folks. And I saw a couple questions here. One was, how does having those genetic dispositions affect addiction in general, or does it differ? That's a great question. Each substance acts a little bit differently, but in general, even if for folks who have potentially have parents who have alcohol use disorders, that not only predisposes one to developing an alcohol use disorder, but actually it appears that that individual might also have increased risk of developing a cocaine use disorder, or developing any addiction predisposes one to developing other addictions down the road. And so we think that they kind of work hand in hand. And in terms of interpersonal problems, yeah, we're talking like arguments with family and friends. You're breaking up with your partners. No one is happy to be around you. And so with all this information, I wanted to get into like how can we educate our people on how to stay safe. And just briefly, there were over 100,000 overdose deaths in 2023. Thankfully, in 2024, we saw this number decline for the first time in the past decade. And we have also seen adolescent overdose deaths increase over the years, and peaking at 721 in 2022. Thankfully, decreasing a bit in 2023 at 708 throughout the U.S. I said I would give a shout out to, I think, was it Allie from West Virginia? Allie, your state, West Virginia, has the highest overdose rate in the United States. And this is in a country, I should also preface, the United States is an outlier. We have more overdose deaths than any other country, by three times the closest country. So overdosing in this way is a uniquely American thing, unfortunately. West Virginia takes the cake in terms of the highest overdose rate in the U.S., but that's followed by all these dark red states. So Alaska, New Mexico, Louisiana, and the Rust Belt really has been hit hard. Tennessee, Kentucky, West Virginia, and Maine as well, DC, Delaware. Um, and why is that? Why have we seen such an increase in overdose deaths? Well, it's primarily you can see this green Mount Everest here. This is synthetic opioids, and synthetic opioids meaning fentanyl. And so the rise of fentanyl is really what has caused the rise in overdose deaths in the past decade. And this chart is looking at even stimulants. We're even seeing an increase in overdoses associated with stimulants. And that is also likely just due to fentanyl and fentanyl being in the stimulant supply. And I know that sounds crazy, but fentanyl these days is found in everything: methamphetamine, cocaine, heroin, fake pills like Xanax or oxycodone. In the DEA, I think that this was from 2022, I want to say that 40% of seized fake pills had some amounts of fentanyl in it. And so I wanted to quiz y'all. What do y'all think? So this is Xanax. One of these is real and one of these is fake. How many folks say left or right for what you think is real? The left, the yellow, or the right, the white? So we got a lot of lefts I'm seeing, couple rights. Actually, the right is the authentic Xanax. You hear this in rap songs all the time, Xannies, bars. Um, how about top or bottom being the real oxycodone? For those of you in the deep in the, gosh, what do they call it? Not trip hop, but like there's some forms of hip hop and rap that talk about drugs a lot. This is the blue 30s, oxycodone 30s. So we see a lot of tops. It looks like y'all did better on that one. The top is the real one compared to the bottom, which is counterintuitive. I have always, looking at this, gotten confused because the printing is much more apparent in the bottom one. But it's actually the counterfeit pill, and it's because a lot of organizations, criminal organizations, have these fake pill presses now, and they're pressing uh, everything. And so, if you know folks that are out there buying pills, just educate them on this. That hey, there could be fentanyl in everything, and there are fentanyl test strips that you can buy, and you don't even have to buy. I guarantee at your school there's someone who's handing these out for free. And so talk to your local counselor, local advisors on who is handing these out. Because if you know folks that are dabbling in cocaine, dabbling in pills, super important that they're testing their drugs beforehand to make sure there's not fentanyl in it. I'm going to breeze through this because y'all aren't kids anymore. But the kids these days, folks in high school, well, actually, you probably took this this survey just this past year. Drug abstinence is at record highs for folks who are in high school. So that's a great news. Alcohol and nicotine marijuana use rates are at record lows among folks in high school. And I think that all this is super promising. I think that we're finally seeing a rise in NA alcohol being sold at bars and things. So I think that this is a really encouraging thing. The biggest concern among high schoolers is that nicotine pouches have increased. I'm sure you guys are seeing this as well, that it's just ubiquitous at this point. A lot of young folks are using these uh, for attention. A lot of folks are developing physical dependence on it, and there are treatments that can help folks with this dependence. And so, if you're having problems reducing your nicotine use, just talk to your provider, and they could certainly help. We're not going to go too much into harm reduction. The biggest thing I want y'all to remember is that, like, if you know folks that are using, like, there are ways to use safer and ways to make sure that your loved ones can stay safe and the folks on your teams can stay safe if they choose to use. The biggest thing, the only way for folks to enter recovery and enter addiction treatment is if they're alive. And so for a lot of folks, helping keep folks alive means giving them access to ways that will keep them alive and help them use in a state where they can still be alive and enter recovery at some point. And I saw someone in the chat earlier talk about the setting. Setting is so important in substance use. And so when you're talking to your people, just remember that like the risk of what you're doing is so dependent on the mindset that you're in when you're using and the environment that you're in when you're using. And for folks that have read much or experienced the psychedelic scene, like we know intuitively that this is really important. That like if you ha if you've probably heard a lot of folks talk about bad trips, that just highlights how important the setting is and the mindset is when you are using a substance. And so trying to help folks use substances with a mindset and in a setting that is healthier can save someone's life potentially. And Kindle, what causes overdoses? Fentanyl is the most common cause of overdoses. And there's a certain part of our brain that when fentanyl binds to it, or any opioid for that manner, any opioid that's prescribed, like oxycodone, hydrocodone, Norcos, all of these, methadone, uh, all of these opioids bind a receptor in our brain that decreases our respiratory rate. And when you decrease your respiratory rate, your body kind of needs oxygen. And so you essentially asphyxiate because your body stops breathing. And that's what causes an overdose. The great news is that there's ways to reverse that. Um, and there's a medication called naloxone or Narcan. Uh, I believe most folks are aware of that medication. And what Narcan or naloxone does is it knocks off all those opioids on that part of our brain responsible for breathing. And so folks usually start breathing right away as soon as you administer the naloxone or Narcan. On top of making sure that folks are using drugs more safely, having naloxone, a really important thing to let folks know about is that they shouldn't be using drugs alone, that they should be using drugs with others, because if their supply happens to have fentanyl or something in it, they could potentially overdose and die by themselves. And that's why supervised consumption is really, really important. So, what are some of the treatments, real quick? I see that we only have about 15 minutes left, so I'm gonna just quickly go through some of the treatments. We know that the majority of folks who have a substance use disorder don't get treatment. That only about 2 out of 10 folks who have an addiction actually get the care that they need. And why is that? Well, a lot of it is because of affordability, access to care, that they're not ready, but also stigma. Like just a lot of folks don't feel comfortable talking to others about their drug use because they're embarrassed by it. Why do they feel embarrassed by it? Well, a lot of people aren't open to talking about it. And so the biggest thing you can do to help folks is to help them feel connected to you despite normalizing their drug use. If you know that they're using, just let them know, hey, I know you're using it. It's okay. I don't view you differently for it. Because the way that stigma works is we see folks, we call folks addicts or coke heads. We label them, and when we create these labels, we attach these negative feelings with it, and people feel those negative feelings when we use these terms. And when they know that you don't view them kindly, of course they're not going to share their use. And so using language that makes people feel comfortable talking to you about their drug use is really important. So instead of calling someone an addict, we call folks someone with a substance use disorder. Or instead of saying that they're dirty, they're using in a dirty way, like we say they're just using substances, or they have substance use, or they're not engaged with treatment currently. Someone asked earlier, like, what are the warning signs for if someone has a substance use disorder? Well, people start acting withdrawn typically, and we notice that their behavior is just a little bit different. They might seem frequently tired or depressed or hostile. Other signs can be that there's a change in their peer group, perhaps, or uh, people might be more careless with their grooming. You see a decline in their performance, either at school or in sports. They're not as interested in their favorite activities. They're getting in trouble. Their eating habits, sleeping habits change, and their relationships change. And so, if you notice these things in someone, you could be the one that just reaches out and says, "Hey, are you okay?" And just being genuinely concerned about their state. SAMHSA has a national helpline, 1-800-662-HELP. And this is a great number to direct people to that can help them access treatment. We are not going to cover these things. Uh, in my field, we say this all the time. If you treat addiction, you save lives. Nicotine use disorder, I won't cover the specific treatments, but we know that there are medications that help people reduce their nicotine use. Patches, gum, varenicline, or Chantix, reducing the amount of nicotine in whatever nicotine supply you're using. There also appears that text-based interventions also might help, and just having a therapist, cognitive behavioral therapy can be really effective. For alcohol use, we also know there are three FDA approved medicines to help people reduce their drinking. One in particular that you guys might be interested in is one called naltrexone. Naltrexone actually blocks our opioid receptor, but it works for alcohol because for a lot of people, when they take that first drink of alcohol, our brain gets rushed with dopamine and things that make us feel good, our natural endorphins. And we think that naltrexone helps block that response. And so there are a lot of younger people, a lot of college people that I know and that I prescribe this to uh, that only take the medicine on days that they know they're going to drink. Because for a lot of people, they don't like that when they drink, they end up drinking way more than what they wanted to. Well, this medication, naltrexone, can be taken on days that you're going to be drinking and help you reduce binges. And so if are curious about that, please reach out and I'm happy to pass on more information about it. There are two other FDA approved medicines for alcohol, but we don't have time to dive into those. There are medications for opioid use disorder. Methadone and buprenorphine are two of the most effective medicines that we have in medicine, period. They help retain folks in treatment and they help reduce overdoses. And when you reduce an overdose, you're reducing mortality. And that is the gold standard of any medicine. Is like if the medicine can save lives, we should be doing more of it. But for some reason, with those two medicines, there's a lot of stigma attached to them. And so I'm happy to field questions, or if you have more questions about those medicines, I can discuss those later. For stimulant use disorder, there aren't as many good medications, but there's some great effective treatments that can be offered both by therapists and by doctors. And so I won't dive into that either in this talk. But does anyone have thoughts on what this is, or why this is? Why I'm ending my slide deck with this picture? Addiction is a slow process. That's good. No matter how hard the turtle tries to get off, they are stuck. Slow and steady wins the race. You guys are getting close. This is good. It needs help. Faye got it. So, how does a turtle get on a post? That turtle obviously did not get there by itself. The same is true with developing addiction. A lot of people who develop addiction, they don't develop it themselves, but it's especially true for recovery. Uh, People don't sustain their recovery by themselves. It's always done with others. And y'all can be those others. You can be the people that helps guide folks into the care that they need and can make people feel comfortable enough to seek help for the state that they're in. And you can be the people that can help be that first step of getting being the starting a turtle in recovery, if you will. So you're welcome to reach out to me anytime if you guys have further questions or concerns that can't be answered in this group environment. This is my permanent email address. And with that, I'm happy to field other questions. Kelsey, there might have been other questions that I didn't address that were asked earlier, so I'll let you start by organizing how to field questions. But I'm so grateful that you guys have invited me into this setting. And I hope y'all feel comfortable reaching out to me anytime if you have questions or concerns about yourself or loved ones.
Thank you, Nick. That was so great. I'm so glad that you were able to share that with all of us. There were a couple of questions that people threw into the chat, and run to one or two of those while other people are thinking of questions, but feel free to raise your hand if you have another question to ask. Um, Someone asked, why are overdose rates so high in the US compared to other countries? What impacts the differences between states?
Yeah, that's a question that people have been trying to answer for a really long time. And it appears that part of the answer is attached to, if you look at those states, a lot of the states with the highest overdose rates are places with economic collapse, places that have lost jobs, where nothing else really moved in to help support them. Uh, I'm going to stop sharing my screen if that's okay. I can put my email address in the chat or phone number. Uh, so we know that addiction takes hold and the drug trade takes hold in places where folks don't have access to resources. It's such an easy and convenient way for people to make money for themselves. Um, and because of that accessibility, we think also that likely a lot of drug organizations know that in the United States, there's a huge market for these sorts of things. And so some of it is supply of labs in China synthesizing certain chemicals that then are shipped to the United States, or criminal organizations in South America or even here in the United States who are trying to sustain and increase their power by increasing their money. And how do they increase their money? Well, they sell these substances and they purchase substances overseas, bring them to the US. So I think because in the US it's just become a big market, uh, that's why we continue to see a steady supply of substances here. But the short answer of why do we see so many overdoses in the United States is fentanyl and the rise of fentanyl. And there's been a lot of, if you're interested in this sort of thing, you should read, just Google deaths of despair and read a bit about the work of those researchers who wrote I'm blanking on the name of the book. It's like Rise and Fall of something, something, something. But they write extensively about why there's been such an increase in overdoses, in alcohol-related disease, and in suicides in certain parts of the United States over others. And that might be a good read to understand a bit more about these dynamics.
Another person asked, what is the percentage, and maybe we don't need an exact percentage, but percentage of people developing mental health conditions like schizophrenia after using things like psychedelics? So maybe the comorbidities between some of our mental illnesses and substance use.
Yeah, it's a really good question. And I don't think we have a definitive answer yet. And a lot of that is because, well, okay, let me even start. Like what we're studying a lot more now is cannabis. Does cannabis increase your risk for schizophrenia later on? They've studied this in a lot of different settings. There's like some uh, town in India where they throw this festival once a year where everyone uses high amounts of cannabis on just this one day. And they can track like, all right, of those people, how many developed schizophrenia based on that one day of use. This is a hard thing to study in just natural settings, by the way, because it's hard to keep track of who's using what, and the anecdotal evidence thing is a challenge and clouds the picture. But from those sorts of studies, it kind of looks like there are some people who are predisposed to developing schizophrenia. That's most likely people who have a family history of schizophrenia or of bipolar disorder. Uh, and in those people, it looks like psychedelics or cannabis can unmask schizophrenia or can unmask your predisposition for developing this mental illness to begin with. Does it directly cause it? We still don't really know, but we think that in the people that do use these substances and develop these mental illnesses, they probably had some sort of predisposition prior to even using the substance.
Does anyone have a question they wanted to unmute and ask? We have a couple more in the chat. We probably only have time for one or two more, but like Nick mentioned, I'll share his contact information with all of you, and hopefully some of the resources in the slides as well we can send out to you. But if you have another question, feel free to unmute and join in.
I was wondering about like caffeine use and like how that, especially like in like younger people and stuff, based on like I don't know, the energy drinks and stuff, like how has that like impacted or what are those numbers and like how is it, I guess, how is the future looking for that?
Yeah, that's a really interesting one that I don't talk to many patients about because it's rare that caffeine causes problems in people's lives. And because of that, I think that we still don't really, it's something that hasn't been studied much because a lot of what I am diagnosing and treating are people who have lost control of their lives because of this substance. Things like these nicotine pouches, these ridiculous amounts of caffeine that are being placed in drinks and in foods and in everything that we ingest these days, or everything that's being sold to us, at least. We don't really know. It's rare that it's causing problems in people's lives immediately. We do know that all of these things increase our anxiety, and a lot of people aren't able to understand that maybe some of the anxiety that they're feeling isn't actually from their work or from their job, that like some of it might be their use of caffeine or nicotine too regularly. Um, I happen to drink coffee every morning and I love my morning cup of coffee. Do I have an addiction? It's possible. My caffeine use hasn't led me to like I haven't tried to quit. I do have cravings. I don't have bad relationships because of it though. So like because of that, necessarily I don't think I would qualify for a use disorder. Now, are there treatments for it? Most of the treatments, like if I became worried about my caffeine use, I would probably talk to my therapist about it and I would devise some sort of strategy to help myself reduce that use. And so, if you're someone who's concerned about your caffeine or your nicotine, or you know someone who's concerned about it, like there's no, like I said, try to distinguish earlier, just using a substance doesn't mean necessarily that you might have a use disorder or problematic use in your life. But if you are someone who is distressed about your use of caffeine or nicotine, it's something you could talk to your doctor or talk to a therapist or even a close friend about to help you figure out strategies to reduce your use over time.
Thank you.
All right. So we are right about at time, and I want to be sensitive of everyone's time. So thank you all for joining us. Thank you again, Nick. That was amazing. And we'll share some of the resources. I'll share the link to that book that Nick mentioned and his contact info with you after the fact. And also you'll have access to the recording if there's anything you want to go back and review. But thanks for jumping on and for asking amazing questions and engaging. And hope you have a good week.
Yes, thank you, everyone. Take care. Reach out anytime. Good luck wrapping up the semester.
Thank you. Appreciate it.
Thank
Thank
you.
you.